This is Immunology, Unit 4, Lecture 4, Viral Hepatitis. Here are your objectives. Hepatitis is inflammation of the liver and is a clinical manifestation of liver disease caused by a variety of bacteria, viruses, fungi, parasites, toxins, autoimmune diseases, radiation, neoplasm, and drugs. Viral hepatitis is liver disease caused by hepatitis viruses. Hepatitis viruses account for approximately 95% of the cases of hepatitis. They attack the liver and rarely affect other organs. We'll start with the hepatitis A virus and go over the epidemiology. This is a member of the Picornaviridae family of viruses and its single-stranded RNA. Transmission of the virus occurs primarily through the fecal-oral route. It is facilitated by conditions of poor sanitation and overcrowding. Most cases are from travel to Mexico or Central and South America. Epidemics generally occur from fecal contamination of a single source of food, water, or milk, and person-to-person spread is responsible for outbreaks linked to daycare centers, mental institutions, and military recruits. The highest titers of hepatitis A are detected in the acute phase stool samples. Infectivity of saliva and urine does not pose a significant risk. So the clinical manifestations, you can be asymptomatic or symptomatic. If you are symptomatic, infections may include a period of jaundice, but most do not. Clinical illness develops with symptoms including fever, anorexia, vomiting, fatigue, and malaise. The most prominent elevated enzymes are ALT and AST, which may increase 10 to 100-fold during the acute stage of the infection. The mortality rate is very low, and treatment is based upon alleviating the symptoms. There are no known antiviral drugs that are effective. The hepatitis A virus vaccine is recommended for healthcare workers and travelers to endemic areas. IgM antibody is present at the onset of symptoms, and a fourfold rise is considered diagnostic. Next is hepatitis B. This is a double-stranded DNA virus. The intact virion is 42 nanometers, and the double-shelled sphere is called the Dane particle. The Dane particle is surrounded by a lipid protein carbohydrate envelope containing hepatitis B surface antigen. If the envelope of the Dane particle is removed, the nucleocapsid remains. The nucleocapsid contains viral DNA, viral polymerase, and hepatitis B core antigen. An antigen found in some hepatitis B surface antigen positive sera is hepatitis B envelope antigen. This is an integral part of the capsid, and hepatitis B envelope is associated with a high level of patient infectivity. Hepatitis B virus is transmitted typically through blood products, accidental needle sticks, IV drug use, and sexual contact, as well as from mother to infant. Infected body fluids include blood, semen, saliva, breast milk, tears, CSF, ascites fluid, and urine. Reservoirs of HBV are chronic carriers of the infection, and all chronic carriers continue to shed active virus. The clinical manifestations can be acute, chronic, asymptomatic, or symptomatic. In the US, 50,000 to 100,000 people acquire hepatitis B each year. However, about 1.25 million people in the US have chronic hepatitis B. You typically have elevated ALT and AST, and no antiviral drug is known to be effective, but vaccines do exist. Next, we'll move on to laboratory diagnosis. Hepatitis B surface antigen is the first detectable serological marker and appears during the incubation period of the infection. Presence of the hepatitis B surface antigen indicates active infection, either acute or chronic. In acute hepatitis B, the titer of the surface antigen declines gradually as the patient recovers, becoming undetectable within 1 to 6 months. In contrast, a chronic infection maintains elevated levels of the surface antigen for 6 months or longer. This is the major coat protein of the virus, and screening for its presence is considered to be the most reliable screen to prevent the transmission of hepatitis B via blood. Hepatitis B envelope antigen appears as the next marker for the hepatitis B infection. The envelope antigen remains at elevated levels that can persist for 6 months or longer. It is associated with the replication of the virus. It is rarely found in the absence of hepatitis B surface antigen. The envelope antigen appears to be a reliable marker for the presence of high levels of virus and high degree of infectivity. If high titers of the envelope antigen persist, the person is highly infectious and is likely to develop serious liver disease. Next is the core antibody. This is the first antibody to appear in the serum. Anti-hepatitis B core develops during the acute illness and remains high for years. IgM appears during the acute stage of illness 1 to 4 weeks after the appearance of the surface antigen and usually drops to undetectable levels within 6 months. IgG is produced during the convalescence and persists for the life of the individual. During the course of most hepatitis B virus infections, the surface antigen forms immune complexes with the antibodies produced as part of the recovery process. Because the surface antigen contained in these complexes is usually undetectable, the surface antigen disappears from the serum in up to 50% of symptomatic patients. The time between the disappearance of detectable hepatitis B surface antigen and the appearance of detectable antibody to the surface antigen is called the core window, or hidden antigen phase of the hepatitis B infection. The core window phase may last for a few weeks, several months, or a year, and during this time, anti-hepatitis B core may be the only serological marker. Next is the envelope antibody. This is detectable shortly after the disappearance of the envelope antigen from the serum in acutely infected individuals. It is the first serologic sign of clinical recovery and decreased patient infectivity. This peaks during convalescence and gradually declines thereafter. In chronic infections, this antibody is never produced unless recovery eventually occurs. And last is the hepatitis B surface antibody. This is a serologic marker of recovery and immunity, either by infection or vaccine. Anti-hepatitis B surface rises during recovery and usually persists for years thereafter, providing protective immunity to the individual. In chronic cases of hepatitis, this antibody is not produced. This is also the only marker found in those who receive the hepatitis B vaccine. So here you have a chart showing when each of these antibodies and antigens spike after infection. And this chart is a really good reference for you guys based on this kind of chart, you need to be able to answer questions about whether someone has an acute infection, a chronic infection, whether they've been vaccinated, those kinds of questions. Next, we'll cover the hepatitis C virus. It was first discovered in 1989 and is a single-stranded RNA virus. There are approximately 25,000 new cases annually in the US. And this high rate of transmission was implicated in 80 to 90% of post-transfusion cases of hepatitis prior to 1992, which is when we began screening blood units for hepatitis C. It is also transmitted via occupational exposure, sexual contact, hemodialysis, bites, acupuncture, tattooing, and body piercing. Also from mother to infant, the risk of contracting hepatitis C virus via occupational transmission is 20 to 40 times higher than the risk of contracting HIV, and this makes it a significant concern for healthcare workers. The clinical manifestations: hepatitis C can result in either acute or chronic disease. Most acute cases are asymptomatic or exhibit mild symptoms such as nausea, anorexia, abdominal pain, fatigue, malaise, and jaundice, so testing may not occur. Hepatitis C is characterized by ALT levels that range between 2 and 800 and marked fluctuations with intervening periods of normalcy. Approximately 60 to 85% of cases become chronic, leading to cirrhosis of the liver in 10 to 20% of the cases. This can occur even if the patient has been asymptomatic. 20% of cirrhosis cases may progress to develop hepatocellular carcinoma. So diagnosing in the lab: ELISA antibody testing for hepatitis C and assays to detect and measure hepatitis C RNA are available. Presence of antibody does not differentiate previous or current infection. Therefore, follow-up testing with detection of hepatitis C RNA would be warranted. A negative antibody test may need follow-up antibody testing to ensure detection of the disease after an exposure. Treatment was previously interferon or ribavirin, which was not well tolerated. Many patients' stated side effects were worse than the disease itself, and yet cure rates were 50% or less. Hervani became available in 2014. It costs $95,000 for a 12-week course of treatment, and it's a combination drug. It has been proven to cure hepatitis C in a majority of people with genotype 1 hepatitis C. It's difficult to receive approval from insurance companies due to the expense of the drug, and a 2-dose vaccine is now in clinical trials and appears promising. Next is hepatitis D. This is also called the delta antigen. It is a single-stranded RNA virus, and infection with hepatitis D can occur at the same time as hepatitis B. Hepatitis D is a defective or incomplete RNA virus that requires the help from hepatitis B. So you can't have hepatitis D without hepatitis B. The epidemiology: it was originally described in Italy. Most cases are Southern European countries. In the US, Northern Europe, and Asia, infection is uncommon. In the US, it is primarily seen in IV drug users and their sexual partners. Hepatitis D accounts for 6% of the viral hepatitis seen in this country. And vaccinations for hepatitis B also provide immunity to hepatitis D. Superinfection with chronic hepatitis B tends to lead to chronic infection with both diseases, and you have a significant higher chance of cirrhosis and liver failure requiring liver transplantation. So as far as lab diagnosis goes, only people that are positive for hepatitis B surface antigen need to be tested for hepatitis D. As far as lab diagnosis goes, only people that are positive for hepatitis B surface antigen need to be tested for Hep D. The first antigen is HDV antigen, followed by IgM, then IgG anti-hepatitis D virus. Some tests are not FDA approved in the United States, and some research facilities can perform PCR for hepatitis D virus RNA. The last one is hepatitis E. This is a single-stranded RNA virus. The epidemiology is a disease of the underdeveloped areas of the world where poor sanitation, overcrowding, and unsafe water supplies are present. All U.S. cases have been linked to recent travel to endemic areas. Hepatitis E virus is transmitted via the fecal-oral route. Hepatitis E is an acute self-limiting disease with symptoms characteristic of hepatitis A. Mortality is low but increases in pregnant women. There is no gamma globulin treatment or vaccine that has been developed as of yet. For lab diagnosis, a short-lived IgM has been found in acute phase sera. IgG appears and replaces IgM after 2 to 4 weeks of symptoms. Duration of detectable IgG remains uncertain, and tests are commercially available, but they are not FDA approved in the United States. So that's all for this lecture. Go ahead and take the quiz on Canvas and make sure you study the chart.